my question to you is, it also ruffles a lot of feathers this is how we've done it, and we've always done it this way. And there's a lot of people who benefit off of the way that we do it. What kind of pushback do you see, having these conversations or trying to do that? I'm really curious.
Yeah, it's definitely, I joke sometimes like healthcare, in particular surgical care, thrives on sort of this like veil of like opaqueness, right? Where we sometimes, patients don't necessarily know all the details of things. Physicians don't necessarily know what each other are doing. APP, like all the stakeholders, there's a lot of
silos.
A lot of silos.
Yeah.
And I have to thank my partners so I'm at Thomas Jefferson right now, and I wouldn't have been able to do this work without my partners in the neurosurgery practice, in the department, supporting it and saying, you know what, like this is kind of part of our mission. It's good research. It's good for patients. And if there are opportunities for us to improve as a part of this, we want to do it.
Yeah.
And that's not trivial at all. So I have to thank, Robert Rosenwasser, my chairman, my division chief, Jim Harrop, and all my partners in our division, Srinivas Prasad, Josh Heller, Jack Jallo, who were game for this. And so transparency is a funny thing. So we took as a proof of concept ACDFs, one level ACDF, and said, let's look at the true intra-op cost of care for this procedure across every surgeon in our division and across every hospital in the 18-hospital Jefferson network and see what we see. And there was incredible variation just on the cost alone for something that we all think of as like kind of a homogeneous thing. I'm not talking about T10 to pelvis fusions or this kind of thing where it's like, well, there's incredible variation. It's a one-level surgery, cervical spine, maybe the closest thing on the sort of implant side of spine to something that is a little bit like nicely packaged up. And there was like 3x, 4x variations in intra-op costs in one health system. What we then did, I think, which I'm proud of, and this is based off of a New England Journal article where this was done for total joints many years ago. We said, okay, it's not enough to just identify variation. Now we want to dig down and figure out what are the drivers of this variation. So we split up the total cost into supply cost and personnel, split up the personnel down to like every single person that comes into that operating room. The circulating nurse, was there a fellow on the case? Was it a RN F first assist, a radiation tech? How many minutes is the radiation tech spending in that operating room? What's the dollars per minute for that radiation tech times the number of minutes they were there, to figure out what are the explanations for these differences in cost. And there were some really interesting, some surgeons are just faster than others, and that's one thing. Some surgeons use less expensive implants. Some surgeons use less expensive biologics. Some surgeons do it the same way every time. So the staff knows I only need to open these 3 trays.
You get efficiency.
The other surgeons, it's like you don't know what's going to happen.
Yeah.
And the rep doesn't want to get in trouble. The circulating nurse doesn't want to get in trouble. They don't want to get yelled at. So they open everything.
Yeah.
And that means the sterilization costs are increased. And we're capturing that as well. And some surgeons don't teach in an academic environment, right? Others teach more. If you teach more, that affects the time.
Yeah.
So all these things we were able to drill down, and then that creates opportunities, right? Where you say, okay, you know what? What if we were to standardize these 4 or 5 sort of low-hanging fruit and then bring down our costs? It's good for the hospital because they're getting paid the same amount for that DRG, but if the cost comes down, their margin goes up. But the big elephant in the room here is the cheapest care is no care.
Yeah.
Right? Like maybe you throw in, something that you picked up on the side of the street into someone's spine and call it an interbody cage, and it's going to be free. And that's really horrible for the patient, right? And so it's not enough to just track the costs. You have to track the outcomes as well. That's why we launched the Prospective Outcomes Registry at Jefferson as well. Because, a classic example is you take a big, large surgery and surgeon X will say, I want gel foam, I want Fibrillar, I want all these expensive thrombotic agents to control bleeding in the surgery. And the hospital committee will come and say, hey, doc, like, we really don't want you to do this stuff anymore. It's like, it's eating into our margins. None of the other people are using this. The surgeon will say, well, my reoperation rate for hematoma evacuation is less. That's why I do it. Nobody has the ability to test that claim in traditional situations. But if you take a given choice that leads to variation in cost in the operating room, and you can track the specific outcome that is relevant to that choice. So in this case, let's look at the probability of reoperation for hematoma takebacks for all the surgeons, for a given type of procedure, for a given diagnosis, and then evaluate the fact that, okay, surgeon X is using something that costs $10,000, but his odds of a reoperation for a hematoma takeback are 30% less than everyone else. Well, what's the cost of a takeback? It's $100,000. You know what? Maybe we should all be using this stuff, because in that situation, it's actually saving money in the long term.
Yeah.
Or if it's a flip scenario where a surgeon says, I need to use this really fancy expandable dual expanding cage because that's going to lead to better fusion outcomes. It's worth it. Trust me, because I'm going to get fewer pseudoarthroses in the future. Well, let's track the outcomes and track the costs over 6 months. And if it turns out that fewer patients are needing reoperations because of that short-term investment you made into a more expensive implant, maybe we should all be doing that. So that's I think the key is to have the outcomes and the cost. And without it, it's just gonna be hatchet jobs all day long. And it's just gonna be less care and cheaper care, but not necessarily better care.